Has a beloved family member begun to exhibit subtle yet profoundly concerning shifts in their demeanor, energy levels, or physical well-being over the past several months? Changes so gradual that you might have initially dismissed them as simply another aspect of normal aging, but which now, as they accumulate and intensify, are causing a quiet unease to settle deep in your heart. I'm Dr. Christopher Blake, and over the course of my 28 years specializing in geriatric and palliative medicine across hospitals and care facilities throughout the United States, I have walked alongside thousands of families during the most sacred and difficult transition that any of us will ever face, the final chapter of a loved one's precious life. What keeps me awake at night, what compels me to create this message for you today, is witnessing families who are caught completely unprepared when that chapter closes. Families who missed the gentle signals their loved one's body was sending for months. Signals that, had they been recognized and understood, could have opened doorways to deeper conversations, more intentional time together, and the opportunity to honor final wishes with dignity and grace. Most people, including many within the healthcare profession itself, operate under the assumption that decline happens suddenly, that an elderly person is relatively stable one day and then experiences a dramatic crisis the next, perhaps a stroke, a fall, or a sudden hospitalization that changes everything in an instant. But the profound reality, the truth that decades of clinical observation and careful research into the dying process has revealed is that the human body begins its preparation for the end of life much earlier than most families realize, often 6 to 12 months before the actual moment of death, manifesting through a constellation of physical, cognitive, emotional, and even spiritual changes that are as natural and predictable as the seasons themselves. A comprehensive study examining patterns of decline in elderly individuals across multiple care settings found that approximately 78% of those who died from age-related causes exhibited at least 3 to 4 recognizable changes in their functioning and behavior during the year preceding their death. Changes that family members later recalled noticing but not fully understanding the significance of at the time. The challenge, the heartbreaking complexity that I witness in my practice nearly every single day, is that these signs often masquerade as benign aspects of aging, easily rationalized away as just getting older, probably tired, or having an off day, when in truth they represent the body's ancient and sacred process of gradually withdrawing from the world, conserving its precious and dwindling energy, and turning inward in preparation for the ultimate transition. For families who love these individuals, who are emotionally invested in their well-being and understandably frightened by the prospect of losing them, acknowledging these signs requires tremendous courage, because recognition forces us to confront mortality itself, to accept that our time together is finite and growing short, and to make difficult but vital decisions about care, comfort, and how we choose to honor the time that remains. What I'm going to share with you today are 5 specific, medically recognized signs that someone you love may be entering their final year of life. Signs that I have observed countless times in my years of practice, explained to hundreds of grieving families, and documented through both clinical experience and the broader body of research in geriatric and palliative medicine. These are not alarmist warnings designed to create unnecessary fear, nor are they absolute certainties. Every individual's journey is unique, and some may exhibit these signs for longer periods or not at all. Rather, they are compassionate guideposts, gentle illuminations along a difficult path, offered so that you might recognize what is unfolding, have honest and loving conversations while there is still time. Ensure your loved one's comfort becomes the highest priority, and prepare yourself emotionally and practically for what lies ahead. All of the medical insights I share are grounded in peer-reviewed research and decades of clinical observation, with sources cited in the description below for your reference. Before we begin this important journey together, I want to ask you to please subscribe to this channel and turn on notifications, because this kind of honest, compassionate guidance about the realities of aging and end-of-life care is information that every family desperately needs but rarely receives until it's too late. Now, let us move forward together with open hearts and clear eyes. Sign number 1, a profound increase in sleep and a gradual withdrawal from social engagement that signals the body's conservation of vital energy. The first sign, one that appears so gradually and innocuously that family members often don't register its true significance until many months have passed, is a marked and progressive increase in the amount of time your loved one spends sleeping or resting quietly with their eyes closed, combined with a subtle but unmistakable withdrawal from social activities, conversations, and interactions that previously brought them joy and connection. You may notice that the person who once rose with the sun and stayed active throughout the day is now sleeping until late morning, taking multiple long naps during the afternoon, and retiring to bed much earlier in the evening, sometimes accumulating 16 to 18 hours of sleep or semi-conscious rest within a single 24-hour period. This is not the temporary fatigue that follows a busy day or a poor night's sleep. Rather, it is a deep, pervasive tiredness that never quite resolves, a bone-deep exhaustion that seems to emanate from some profound source beyond mere physical exertion. From a physiological perspective, what is occurring within the body during this stage is both complex and deeply purposeful, reflecting the organism's ancient wisdom as it begins the process of shutting down non-essential functions and redirecting every available unit of energy toward maintaining only the most critical systems: the beating of the heart, the inflation of the lungs, the basic metabolic processes that sustain cellular life. Research into the dying process has documented that as organ systems begin their gradual decline, particularly the cardiovascular and respiratory systems, the efficiency with which the body produces and distributes energy at the cellular level diminishes substantially, often by 30 to 40% compared to baseline functioning. This means that activities which once required minimal effort, walking across a room, engaging in a 10-minute conversation, sitting upright at the dinner table, now demand disproportionate amounts of energy that the body simply cannot spare without consequences, and so the person naturally compensates by sleeping more, moving less, and narrowing the scope of their engagement with the world. The emotional and psychological dimensions of this withdrawal, however, extend far beyond simple physical fatigue, touching upon something more existential and spiritually significant that many cultures throughout human history have recognized and honored. As individuals move closer to the end of life, there often emerges what palliative care specialists describe as a natural turning inward, a redirection of attention away from the external world of relationships, activities, and sensory experiences, and toward an internal landscape of memories, reflections, and perhaps spiritual preparation. Your loved one may seem less interested in the daily news, less invested in the outcomes of family dramas or neighborhood gossip, less responsive to invitations for outings or social gatherings, not because they no longer care about these things or about the people involved, but because their consciousness is gradually shifting to a different plane of existence, one where worldly concerns hold less weight and ultimate questions take precedence. For families witnessing this transformation, the experience can be profoundly disorienting and emotionally painful, particularly if you interpret the withdrawal as personal rejection or as a sign that your loved one is giving up or becoming depressed. I vividly recall Margaret Rosen, an 84-year-old woman from Portland, Oregon, whose daughter brought her to me in distress because Margaret, once the vibrant social center of her retirement community, had stopped attending card games, declined invitations to group dinners, and began spending most of her days in her favorite armchair by the window, eyes closed, a peaceful expression on her face. The daughter was convinced that her mother was severely depressed and wanted aggressive intervention with medications and therapy. After a gentle and thorough evaluation, however, it became clear that Margaret was not suffering from clinical depression, but was instead experiencing this natural withdrawal, this peaceful turning inward that her body and spirit were guiding her toward. When I explained this to the daughter, when I helped her understand that her mother was not abandoning her but rather preparing for a different kind of journey, the daughter's fear and hurt transformed into something more tender and accepting, and she was able to spend Margaret's remaining 6 months simply sitting beside her, holding her hand, offering quiet companionship without expectation or demand. The broader implications of this sign extend into practical considerations about how families can best support their loved one during this stage, ensuring comfort while respecting the natural process that is unfolding. It is crucial to understand that forcing activity, insisting on social engagement, or expressing frustration about excessive sleep can create unnecessary distress for someone whose body is crying out for rest and whose spirit is seeking quiet. Instead, the most compassionate response is to honor this need for withdrawal while ensuring that basic needs for comfort, nutrition when desired, and gentle presence are met. Create a peaceful environment with minimal noise and stimulation. Allow them to sleep as much as their body demands without guilt or pressure, and when they are awake and receptive, Offer your loving presence without the expectation of lengthy conversation or effortful interaction. Simply sitting nearby, perhaps reading quietly or engaging in a gentle hand massage, communicates love and support without depleting their precious energy reserves. It is equally important during this stage to pay attention to the quality of sleep and rest your loved one is experiencing, because not all increased sleep is the same, and certain patterns may warrant medical attention to improve comfort. If their sleep seems restless, punctuated by frequent awakening, moaning, or expressions of discomfort, these may be signs of unmanaged pain, medication side effects, or other treatable conditions that are compromising their rest. Similarly, if you observe extreme confusion or agitation when they wake, or if they seem unable to rouse at all, even with gentle stimulation, these may indicate complications that require evaluation by their healthcare provider. The goal during this stage is not to reverse or fight against the natural increase in sleep. That battle cannot and should not be won, but rather to ensure that the sleep they are experiencing is as peaceful, comfortable, and restorative as possible, free from unnecessary suffering. Sign number 2, a marked decrease in appetite and interest in food, often accompanied by significant weight loss, that reflects the body's changing nutritional needs. The second sign that frequently appears during the final year of life, one that causes tremendous anxiety and distress for family members who equate feeding with love and caregiving, is a progressive and often dramatic decrease in appetite, a loss of interest in foods that were once favorite treats or comfort meals, and a rejection of eating that may feel to you like your loved one is giving up or starving themselves, when in fact their body is following an ancient biological program that no longer requires the same nutritional input it once did. You may find that the person who previously enjoyed 3 full meals a day plus snacks is now barely touching their breakfast, refusing lunch entirely, and perhaps taking only a few spoonfuls of soup or a few bites of soft food at dinner before pushing the plate away with a gentle shake of the head or a soft assertion that they simply cannot eat another bite. The physiological mechanisms driving this appetite loss are multiple and interconnected, reflecting broad systemic changes as the body's metabolic requirements decrease and digestive function becomes less efficient. As major organs, particularly the liver, kidneys, and digestive tract, begin their gradual decline in function, the body's ability to process, digest, and extract nutrients from food diminishes correspondingly, sometimes by as much as 50 to 60% of baseline capacity. This means that the act of eating, which should theoretically provide energy and sustenance, may instead demand more energy to digest than it ultimately provides, creating a net negative energy balance that the weakening body instinctively seeks to avoid. Additionally, many elderly individuals in their final year experience alterations in taste and smell perception, changes that can make previously delicious foods taste metallic, bitter, or simply bland and unappealing, further reducing the motivation to eat. Research examining nutritional patterns in end-of-life populations has consistently documented that appetite decline typically begins subtly, perhaps a slight reduction in portion sizes or skipping an occasional meal, but accelerates over time, with many individuals consuming less than 30% of their previous caloric intake during the final 3 to 6 months of life. This weight loss, which may amount to 20, 30, or even 40 pounds over the course of several months, is not the result of deliberate starvation or neglect, but rather reflects the body's decreased energy expenditure as activity levels plummet and metabolic processes slow to a fraction of their former rate. The body, in its ancient wisdom, recognizes that it no longer needs the same fuel it required when it was maintaining full activity, repairing tissues, and sustaining all systems at optimal function, and so it naturally reduces its demand, signaling this reduced need through diminished hunger cues and satiety signals that trigger much earlier in the eating process. For family members, witnessing this appetite loss and weight decline can be one of the most emotionally challenging aspects of caring for someone in their final year, because across virtually all human cultures, the offering of food is deeply intertwined with expressions of love, comfort, nurturing, and connection. When your loved one refuses the meals you've prepared with such care, when they can't finish the special dessert you brought because you remember it was their favorite, when their clothing hangs loose on a frame that seems to be disappearing before your eyes, it is natural to feel helpless, frightened, and perhaps even angry or rejected. I once treated an elderly man named Robert Chen from Sacramento, California, whose wife of 57 years was beside herself with anguish because Robert, who had always been a hearty eater and appreciated every meal she prepared, had lost nearly 35 pounds over 4 months and would take only a few bites of food before stopping. She was preparing elaborate dishes, trying every recipe she thought might tempt him, spending hours in the kitchen, and then collapsing in tears when he couldn't eat what she'd made. Her grief was not really about the food itself. It was about feeling powerless to help the man she loved, about watching him fade away and being unable to stop it, about the primal fear that if she could not feed him, she was failing in her most basic duty as a caregiver. What I had to help this devoted wife understand, what I need you to understand, if you are witnessing this sign in your own loved one, is that forced feeding or aggressive nutritional intervention during the final stages of life often creates more suffering than it alleviates, and that honoring your loved one's reduced appetite is, paradoxically, one of the most loving acts you can offer. When a dying body is forced to process food it no longer needs or can efficiently digest, the result is often profound discomfort, nausea, bloating, vomiting, diarrhea, or constipation that adds unnecessary suffering to an already difficult transition. The body is not crying out for food. It is asking to be left alone, to be allowed to conserve every remaining unit of energy for the essential functions that truly matter in these final weeks and months. Your loved one's refusal to eat is not a rejection of your love or care. It is a signal that their body has different needs now, needs that cannot be met through food, but rather through presence, comfort, and acceptance. The most compassionate approach during this stage is to shift your focus from the quantity of food consumed to the quality of the eating experience, and more importantly, to the broader question of comfort and connection. Offer small portions of foods that are easy to swallow and digest. Soft foods like yogurt, pudding, ice cream, soup, mashed potatoes, or smoothies, without expectation that they must be finished. Allow your loved one to eat whatever they desire, whenever they desire it, without judgment about nutritional balance or dietary restrictions that may have been important in earlier stages of life, but are now largely irrelevant. If they want ice cream for breakfast or decline vegetables entirely in favor of a few bites of bread with butter, honor those preferences completely. Focus on the social and emotional aspects of mealtimes rather than the act of eating itself. Sit together, share memories, hold hands across the table, engage in gentle conversation if they are receptive, creating connection that nourishes the spirit even when the body is no longer nourished in the traditional sense. It is also vital during this stage to maintain excellent oral hygiene and mouth care, even as eating decreases, because a dry, uncomfortable, or unclean mouth can cause significant distress and further reduce any remaining appetite or interest in food. Offer frequent small sips of water, ice chips, or moistening swabs to keep the mouth comfortable. Brush teeth or dentures gently after any food intake, and apply lip balm to prevent painful cracking or dryness. These simple comfort measures can make an enormous difference in your loved one's quality of life during this time. It is equally important during this stage to pay attention to the quality of sleep and rest your loved one is experiencing, because not all increased sleep is the same, and certain patterns may warrant medical attention to improve comfort. If their sleep seems restless, punctuated by frequent awakening, moaning, or expressions of discomfort, these may be signs of unmanaged pain, medication side effects, or other treatable conditions that are compromising their rest. Similarly, if you observe extreme confusion or agitation when they wake, or if they seem unable to rouse at all, even with gentle stimulation, these may indicate complications that require evaluation by their healthcare provider. The goal during this stage is not to reverse or fight against the natural increase in sleep. That battle cannot and should not be won, but rather to ensure that the sleep they are experiencing is as peaceful, comfortable, and restorative as possible, free from unnecessary suffering. All of the medical insights I share are grounded in peer-reviewed research and decades of clinical observation, with sources cited in the description below for your reference. Before we begin this important journey together, I want to ask you to please subscribe to this channel and turn on notifications, because this kind of honest, compassionate guidance about the realities of aging and end-of-life care is information that every family desperately needs but rarely receives until it's too late. Now let us move forward together with open hearts and clear eyes. If you are finding this information valuable, if it is helping you understand what you are witnessing in your own family, or preparing you for what may lie ahead, I want to ask you to please take just a moment right now to click that like button below this video. Your engagement helps us reach more families who desperately need this kind of honest, compassionate guidance about the realities of end-of-life care. And please, if you haven't already, subscribe to this channel and turn on notifications so you never miss future videos that address the questions and concerns that matter most to you during this difficult journey. Now let us continue with the remaining signs. Sign number 3, increasing cognitive fluctuations, disorientation to time and place, and episodes of confusion that reflect reduced blood flow and oxygenation to the brain. The third sign that frequently emerges during the final year of life, one that can be particularly distressing for family members to witness because it strikes at the core of identity and personhood, is a progressive pattern of cognitive changes characterized by fluctuations in mental clarity, increasing disorientation to time and place, episodes of confusion where your loved one may not recognize familiar people or surroundings, and periods where they seem to be experiencing or responding to realities that you cannot see or understand. These changes may manifest as asking the same question repeatedly within a span of minutes, mistaking the current year or season, expressing a belief that they need to go to work despite having been retired for 20 years, or failing to recognize a family member who visits regularly. You might also observe periods of remarkable clarity interspersed with episodes of profound confusion, creating a fluctuating pattern that is emotionally exhausting for everyone involved and that makes it difficult to predict from one day or even 1 hour to the next what level of cognitive function will be present. The physiological underpinnings of these cognitive changes are rooted primarily in the cardiovascular system's declining ability to deliver adequate oxygen and nutrients to the brain, an organ that, despite comprising only about 2% of total body weight, consumes approximately 20% of the body's oxygen supply and requires continuous, robust blood flow to maintain optimal function. As the heart weakens in its final stages of life, as blood pressure drops, and as the vascular system becomes less efficient at distributing blood to all regions of the body, the brain, particularly the complex frontal and temporal regions responsible for memory, orientation, executive function, and rational thought, begins to experience what researchers describe as a chronic state of relative hypoxia or insufficient oxygenation. This oxygen deficit does not occur uniformly or constantly. Rather, it tends to fluctuate based on positioning, activity level, hydration status, infection, and a host of other variables, which explains why cognitive function may seem relatively preserved in the morning after a night of rest but deteriorate significantly by evening, or why your loved one might be lucid during one conversation and deeply confused during the next. Research into terminal delirium and end-of-life cognitive changes has documented that approximately 60 to 80% of individuals in their final months of life experience at least some degree of confusion, disorientation, or altered mental status, with the severity and frequency of these episodes typically increasing as death approaches. These cognitive fluctuations are not necessarily indicative of Alzheimer's disease or other primary dementing illnesses, although individuals with pre-existing dementia certainly may experience worsening of symptoms. Rather, they represent a secondary effect of the dying process itself, a reflection of the brain's diminishing capacity to function normally as its foundational needs for oxygen, glucose, and metabolic stability are no longer adequately met. The experience from the individual's perspective may include visual or auditory hallucinations, seeing deceased loved ones, hearing voices, perceiving presences in the room that others cannot detect, phenomena that have been reported across cultures throughout human history, and that may represent neurological misfiring, spiritual visitation, or simply the brain's attempt to make sense of sensory input that is no longer being processed reliably. For families, these cognitive changes often trigger profound grief and fear because they seem to signal the loss of the person you love even before their physical death, a phenomenon sometimes described as anticipatory grief or ambiguous loss. I remember so clearly an elderly woman named Dorothy Patterson, 89 years old, from Tucson, Arizona, whose son brought her to me in acute distress because Dorothy had begun asking daily when her long-deceased husband would be coming home from work, insisting that she needed to start preparing dinner for him, and becoming agitated when her son tried to redirect her or remind her that his father had passed away 15 years earlier. The son, a devoted and loving caregiver, was tormented by these interactions. uncertain whether he should play along with his mother's confusion to keep her calm or repeatedly correct her to try to maintain a connection to reality. He felt as though he had already lost her, that the mother he knew was gone, replaced by this confused and disoriented stranger who lived in a past that no longer existed. What I helped this son understand, what I need you to grasp if you are facing similar confusion in your own loved one, is that these episodes of disorientation and cognitive fluctuation are not deliberate, are not indicative of emotional weakness or mental failure, and often are not significantly distressing to the person experiencing them, even though they are heartbreaking for family members to witness. When Dorothy asked about her deceased husband, she was not necessarily suffering. In that moment, her reality included his presence and their shared life together, and attempting to force her back into the present reality with corrections about his death only created agitation and confusion that served no protective or beneficial purpose. The more compassionate approach, the one that prioritizes her comfort over factual accuracy, was to respond gently with something like, "He'll be here soon. Let's sit together until he arrives." Or, "I'm sure he's on his way." Responses that validated her experience, reduced her anxiety, and allowed her to rest peacefully in whatever reality her mind had constructed. This approach, sometimes called therapeutic fibbing or validation therapy in palliative care settings, is not about lying or being dishonest. It is about recognizing that truth and reality are fluid concepts when the brain is actively dying, and that imposing our version of reality onto someone who can no longer reliably process it creates unnecessary suffering. Beyond these interpersonal strategies, there are also practical environmental modifications that can help reduce confusion and enhance safety during this stage. Maintain a consistent, simple daily routine as much as possible because predictability and familiarity provide cognitive anchors even when memory and orientation are compromised. Keep the living environment well lit, especially in the evening hours when confusion often worsens, because shadows and darkness can enhance visual misperceptions and hallucinations. Remove or minimize mirrors if your loved one no longer recognizes their own reflection, as this can be frightening. Place clocks and calendars in visible locations, though understand that these tools may not always be processed or helpful. Most importantly, approach your loved one slowly, identify yourself clearly and gently, and provide reassurance through touch, tone of voice, and calm presence, rather than through complicated explanations or reality orientation that their brain can no longer reliably process.